Maternal mortality in Afghanistan, public health interventions from a public health nurse. Even with modern medicine and state-of-the-art facilities, giving birth is still the most dangerous condition for a woman. If you are a woman living in Afghanistan, then you have the greatest risk for mortality, greater than anywhere else in the world. 1 in 11 women will die during pregnancy and/or childbirth. While 98% of maternal deaths are preventable through proven and cost-effective measures, in Afghanistan there is a great lack of resources and infrastructure to meet the demands for maternal services. This can be attributed to several factors. Cultural barriers, the way the newborn is cared for, and beliefs regarding breastfeeding and nutrition, the belief that going to doctors is bad, and that one should seek alternative sources of help, such as home remedies, looking for mullahs, or administering self-medication. And this is exacerbated by the fact that in Afghanistan, it's shameful to seek help from medical professionals that are male, unless they're members of your family, close members of your family. Under facilities, lack of access to birthing facilities or any kind of comprehensive and emergency obstetric care. Often the facilities that do exist are in urban areas, and due to the limited number of them, there are often long wait times and lots of out-of-pocket expenses. These expenses include lodging and food, and the lack of skilled birthing attendants and midwives. The number is rising, however, there is still a great shortage in rural areas of skilled birthing attendants and midwives, with some estimates being that only 23% of the estimated need for skilled birthing attendants being met by the existing workforce. Poverty, with 36% of its population living below the poverty line, Afghanistan is only second to Bangladesh as Asia's poorest country. Like most countries, the poverty is mostly concentrated in rural areas. For example, 90% of urban households have electricity, while only 26% of rural households do. And Afghanistan has a decades-long history of conflicts and war, and this has contributed to the overall lack of infrastructure and poverty. So I put this graph in here because I wanted to show that maternal mortality has decreased since the 1990s, and it's decreased considerably. However, if you look at Afghanistan in comparison to other Southeast Asian countries, you see that they still lag far behind in the improvement in maternal death. And so while they have made considerable improvements, they still have some a long ways to go. So as a public health professional, we like to look at this issue from a socio-ecological framework to help define the various elements related to the issue. From an individual level, the majority of Afghan women give birth at home due to a large variance in access to resources between rural and urban dwellers. In addition, it's estimated that only 7% of those women who give birth at home have a skilled birthing attendant or midwife present. And because hemorrhage is by far the leading cause of maternal death, it is essential, that skilled birthing attendants be trained to spot the signs of postnatal hemorrhage and be able to intervene with active management of third-stage labor process. From an interpersonal perspective, beliefs against family planning and contraceptive use. From an organizational level, the biggest hindrance is ill-equipped healthcare systems and providers that just don't have the ability to deliver comprehensive obstetric and emergency care. So, as I mentioned before, there is a large discrepancy in access to care between rural and urban Afghan women. A report by UNICEF shows a near total absence of accessible hospital services for complicated births. From a community level, health literacy is a large problem. It remains very low, with estimates being that only 4% of women between the ages of 20 and 29 being literate, and only 26% of their husbands being literate. This creates a large health literacy barrier, which is compounded by the cultural distrust of midwives and the prohibition of male healthcare workers taking care of females. As a public health nurse, the focus again needs to be on supporting the ongoing initiatives and helping to educate and train. This includes the development of curriculum programs for midwifery training and support with teaching and training of skilled birthing attendants. Lastly, from a policy level, one of the greatest barriers is the weak national health system. Years of war and economic instability has devastated the framework of the previous health system. So after the collapse of the Taliban in 2001, the Ministry of Health adopted the Package of Health System, BPHS, and they contracted the management of this health delivery to non-governmental agencies. While the BPHS has showed great improvement in increasing the health factors in Afghanistan, there's still widespread inequalities. Unfortunately, in absence of a strong accountability system, some of the critics of the BPH say that it is more curative than preventative, and again, it's mostly urban focused. So challenges and barriers to maternal mortality in Afghanistan really fall into three main categories. These are post-delivery and maternal and newborn care practices, care-seeking practices and access to health services, family and community support for new mothers. Some interventions. From the perspective of a public health nurse, the most important resource required for creating an integrated health system for pre- and postnatal care really is the infrastructure required for private space in the hospital delivery ward. And private space is important because in Afghanistan, males are not allowed in the delivery ward or in the delivery room. Therefore, they cannot participate in essential family planning and health education discussions with healthcare providers. And it can be difficult to overcome this barrier. Of course, infrastructure is always a difficult barrier to overcome. We can work towards building freestanding counseling rooms or even reallocating space somewhere else in the hospital. But it really is essential in creating a supportive family environment. Maternal waiting homes. Maternal waiting home, it's a type of outreach service that provides healthcare, screenings, and preventative services such as immunizations and contraception. They can also provide access to general obstetric care and emergency care to women in areas of Afghanistan without a hospital. So it's not going to be a tertiary care center, but it can be an intermediary between a basic clinic and a tertiary care center. It can provide some more services than a basic clinic can. And lastly, because postpartum hemorrhage is responsible for over 56% of maternal deaths in Afghanistan, the education and promotion of active management of third stage labor is one of the most critical and life-saving interventions that a public health nurse can influence. Maternal and Child Health Integrated Program, it's a division of USAID. They have identified a 3-step process that can reduce postpartum hemorrhage by as much as 2/3. This includes the use of uterotonics, safe delivery of the placenta, and uterine massage. So how do we know that our interventions have been successful? Well, we can look at an increase in skilled birthing attendants and midwives, a decrease in maternal death due to hemorrhage, an increase in contraceptive use, a decrease in unplanned births, an increase in use of outreach clinics, and an increase in grant funding. I put this infographic up here because I thought that it was interesting to see that the episodes of care have increased through family planning visits for pre-pregnancy in women of all reproductive age, through antenatal care, through birth, through postpartum, and postnatal. And I thought that that was promising to see that these interventions have made some significant impacts in the episodes of care available to women in Afghanistan. This infographic also shows the MDG, Millennial Development Goal target of 75%, and for proportion and reduction in maternal mortality. And while Afghanistan didn't quite reach the 75% target, they got close. And so again, I wanted to just reinforce some of the efforts that have taken place in Afghanistan. And lastly, the logic model shows the inputs I spoke about, outputs and outcomes. But what I want to focus on is the long-lasting impacts. And I'm hoping that with these interventions, the AMTSL becomes the standard of care and best practice throughout Afghanistan, and not just localized or specific to urban areas and larger tertiary care hospitals, but that it's able to really be taken down to a community level where skilled birthing attendants are able to use the 3-step process with women giving birth at home. I'd like to see an increase in access to skilled birthing attendants and midwives so that every community in Afghanistan and every village has enough skilled birthing attendants to meet the needs. And cultural acceptance of family planning and contraceptive use. Of course, this could take several generations. However, I think that the groundwork has been laid and it's starting to become effective in the number of women using contraceptives now, and also the idea of family planning in general being more acceptable. And of course, none of this could be possible without the continued growth and funding of outreach medical services, and that's a big one. The funding needs to be there in order to be able to continue with the services that have already been provided and the programs that have already been established. Thank you.